Today's guest isn't just one of the world's most respected cardiologists. He's a man who's challenged decades of conventional wisdom and reshaped how we think about fitness, fat, and heart health. You've seen his research cited across the globe, from major journals to primetime media. But before the Obesity Paradox became a conversation starter in almost every gym across America, he was just a kid who loved sports and had a relentless curiosity about what makes the human body tick. In this episode, Dr. Chip Lavie and I unpack one of the most misunderstood topics in fitness today: why some people who are overweight may actually outlive their leaner counterparts, and why fitness, not fat, might be the ultimate predictor of health. We'll talk about VO2 Max, METs, body fat versus lean tissue, and the surprising data behind semaglutides and modern weight loss drugs. Whether you're a coach, a clinician, or someone just trying to make sense of the headlines, this episode is the one that cuts through the noise. Let's get into it with the man who says it best: fit is it. All right, Dr. Lavie, thank you for joining us on the show today. Really excited to have you. And there's a lot of research that's going around, and some of the research is on one side of the field, and then the other research seems to be on the other side of the field. And you get into some of these things in fitness where maybe you get distracted by what you're seeing on social media channels. And this has a huge impact on the way that people may represent themselves or how they see themselves in the mirror. But before the studies, right, before the headlines that you had, because you've been everywhere, who was Dr. Lavie growing up? That's what I really want to know, because I want to know that kind of leading into kind of your origin story, the background on you, why you got into this stuff. What shaped you?
Yeah. So growing up, I mean, as a kid, I was very much into sports and played baseball, basketball, particularly. And I planned on, being a college player, and possibly could have, but I didn't end up doing it. Got into college and realized that at first I thought I was going to do dentistry, and then quickly realized that medical field would be better. And then got into medicine and quickly learned that the leading cause of death is cardiovascular disease, and particularly atherosclerosis. And so, we should be trying hard to prevent that. And so that led me to gravitate toward becoming a specialist in cardiovascular diseases. And in medical school, I got very interested in, I was always athletic and always physically active, but I got very interested in running. And, started running races and it was a little bit hard to do that during residency and fellowship. But then afterwards, when I came back to New Orleans, I really started doing lots of races. And some years I was doing, 40 races a year. And so I went on streaks at times where I didn't miss a day of running for 4 years straight, and things like that. And, that's kind of how, my background for being interested in the area. I really got interested in the science of it when I was at the Mayo Clinic with people like Ray Squires, and later in my career with a guy named Steve Blair, who I consider the father of aerobic fitness. And so from an academic standpoint, those two, and then a guy who joined me very early when I came back to Oshner after my fellowship at the Mayo Clinic was Richard Milani. And, he and I did a lot of work on cardiac rehab and exercise training. In more recent years, I've been doing a lot of work not just on cardiac rehab, but physical activity, exercise, and fitness in general. But, we did a lot of the major original, research studies in the field of cardiac rehabilitation.
So you trained at the Mayo Clinic, right? I mean,
yes.
And then you went on to become really kind of one of the top cardiologists in the world, with all these research papers. You came out with a book, Obesity Paradox, which was based on some research that you did. And what kind of gave you the courage to challenge decades of accepted medical doctrine? I mean, you kind of went against the grain a little bit that's why it's the paradox, right? So
So I mean, I always thought obesity, was bad, and gaining weight, was not a good thing. And I have, that has not changed. And so sometimes people say what I'm saying about the obesity paradox. But, I really thought that, that people that are obese get more heart disease. And that's true. And they get, more heart attacks and more atherosclerosis. They get more heart failure, get more atrial fibrillation. 3 decades ago, if I was sitting with two patients in rooms that both had just had a heart attack, and one of them had a BMI of 22 and the other one had a BMI of 32, I would have thought that the prognosis would be better for the person with the BMI of 22. And that is totally not the case. And so the way I actually got interested in this idea, though, was by accident, that we were doing a research study on cardiopulmonary stress testing. And Richard Milani and Mandeep Mehra, both thought that, okay, we know that they use in the cardiopulmonary to peak VO2 to predict who needs to get a heart transplant when they have very weak hearts. But we thought that, okay, if normally people say their peak VO2 in oxygen per kilogram per minute, we thought that rather than doing total kilograms, total weight, if we used lean mass, it would predict the prognosis better, because we knew that fat did not receive the same amount of blood flow and wasn't as metabolically active. Now, we now know many years later that fat is a very, very important endocrine organ, but it is true. It doesn't get the same blood flow as muscle. It doesn't get the same perfusion. It doesn't get the same high level of metabolism. So when we did that study, we showed that peak VO2 corrected for lean mass was a much better predictor of survival in these people with very bad hearts. But when we first saw the data, the people who died had a lower BMI and a lower percent body fat than those who were surviving. And so when I first saw that data, I said, oh, the fellow must have mixed up the columns. It just must be the opposite of that. So I said, go back and check it. And of course, it was correct, that the people who died had the lower BMI and the lower percent body fat. And so that then got me interested initially in heart failure, but then we did it, many, about coronary disease patients. And it's been done now for every type of heart patient, that maybe the bigger person, the heavier person, maybe wouldn't have gotten the heart disease in the first place had they remained lean and fit their whole life.
So
once they develop the heart disease,
I want to give some context for the listeners, because I don't know if all of them understand VO2 max. And I don't know if all of them might understand, the analogy that you just gave, or not even analogy, just the measurement, that you gave. Yeah. So VO2 max, ventilated oxygen per minute, right? That's using gas exchange and measuring the oxygen intake, which is generally considered the gold standard for determining fitness. Right, because
how much oxygen, if you can get a high level of oxygen in, when you're exercising, those are very fit. And so people who are like top marathon runners are going to be at very high levels. People who are top bikers are going to be at very high levels. And so a low level is indicative of low fitness. And the people with low fitness generally have a much worse survival for almost everything.
So, and when you were measuring your analysis of the measurement of the lean body mass, right? So let's say someone's 200 pounds considered obese, but you recalculated this for lean body mass. So let's say their lean body mass weight was 160. That takes out all visceral and subcutaneous fat, so the fat that's inside the body around the organs.
Yeah. So basically, you can measure percent body fat, And so we did it by a simplified technique called the sum of the skin fold methods by measuring the subcutaneous fat at different areas. And that's not the most accurate way. The most accurate way is using things like DEXA scans. You can do certain types of MRIs to really see all the fat all over the body. But we did a really simple technique. And so if we had a person who weighed 300 pounds and we did the percent, the skin folds, and it estimated that their percent body fat was 40%, then we'd take 40% of 300 and that would be the fat mass. And then the rest would be lean mass. And, or another way to say that would be non-fat mass. Or if it was 50%, then 300 pounds, then we would say it was 150 pounds of non-fat mass or lean mass. And so we showed that with that the oxygen corrected by the lean mass was a better predictor of survival than the oxygen corrected for the total mass.
So this,
but like I said, the
person is essentially, it has a lower morbidity rate than the same person, but is actually thinner, but their body fat percentage might be greater.
Yeah. So we showed that because to get the lean mass, we had to get fat mass. We showed that percent fat, which we would have thought would be bad, actually was protective in these heart failure patients. Now, again, and that's the obesity paradox, meaning that among heart disease patients, and the same thing is true for many cancers and end-stage renal disease, HIV or AIDS disease, that in many of established chronic diseases, that the heavier are having a better prognosis. And that is called the obesity paradox. And again, I don't want to mislead because I clearly believe, and I think it's been shown that obese, heavier people get more heart disease. Mm-hmm. So in a perfect world, everyone would remain lean and fit. But what happens with aging in our society is many people gain weight, and many people gain a lot of weight, and they lose their fitness. And so the people who gain weight, they get, for example, heavier people get more heart failure. They get more atrial fibrillation. When the weight goes up, the triglycerides goes up, the sugar goes up, the inflammation goes up, the blood pressure goes up. And so then they get more hardening of the arteries. And so they get more heart disease. And so that hasn't changed. We know that. It's just that when you take the two people who have the same heart disease, the thinner is doing worse. So, and that's the obesity paradox.
Could this be similar to the, maybe the same parallel that you might draw from professional athletes? I have some friends who have played professional sports, and they come off of their professional sports career. And they're so used to consuming a lot of food because they're also training extremely hard, and they're very fit, but then they stop and they maintain their same living situation with food. Right? That hasn't changed, but they stop training because they're no longer doing that sport. They find themselves in like a job where they're seated or sedentary. They are getting more overweight or obese in some cases. And then they find themselves with, heart complications. Is that the relation that you can draw, or the parallel that you can draw, because they're going to fat and they're losing their fitness while they're getting
So probably that professional athlete that you just described probably lost some of their fitness as they stopped training and gained all the weight too, and gained a lot of fat. But they may not have lost all of their fitness.
Right.
First of all, you gave an example of someone, a professional athlete. So that means they also, not only did they train hard, generally to become a professional athlete, you have some natural ability. Mm. So there's some selection bias, and so even as they get older, and even as they stop training, and even as they gained a lot of weight, they probably still fitter than a lot of people because of they were so fit to begin with, and they were and maybe naturally really good athletes. I think that's probably not the best example though, because I think that the best example probably would be the two people who finish high school at 160 pounds. And one person, and again, hardly anybody keeps this high school weight as they go into adulthood. I don't know about okay. But one person was weighing 160 in high school, and then over the next 40 years, they gained 20 pounds. So instead of being 160, they 180. Whereas his buddy started at 162, but at age 60, he's weighing 260. He gained 100 pounds instead of just 20. And so with the 100 pounds, his triglycerides went up, his blood pressure went up, his sugar went up, his inflammation in the blood went up, his good cholesterol went down. So everything, went in a bad direction. And so when those two people get heart disease, you would think that the thinner would do better. They have a lower blood pressure, better lipids, better sugar, less inflammation, and they do worse. But the reason is nobody knows this for sure, but the reason probably is that the thin person got the heart disease because of genetic susceptibility, because because of their genetics. Maybe they had family history, whereas the heavier person may not have gotten the heart disease to begin with if they would have stayed 160 or maybe just gained 20 pounds and went to 180 instead of 260 pounds. And but then once they both sitting in my office with heart disease, like I said, 30 years ago, I would have thought that the heavier would do worse. And all the studies in the past 20, 30 years are showing that the heavier is in fact doing better.
So all things being equal, that example you gave, that 180 pound person walking into your office, that 260 pound person now walking into your office, let's say they both have heart disease, right? Take genetics out of the equation. Which one in that scenario would naturally recover better or be able to do better? Is it that person who's more overweight because they have protection?
Well, that's what the stats, generally the stats show, that among heart disease people, that the odds of doing better are greater in the heavier compared to the thin. But what is very important is the fitness. And if you measured fitness, and you can measure fitness the gold standard way with the gas exchange and measuring peak oxygen consumption. Or you can measure fitness by a 6-minute walk test. Mm-hmm. Or you can measure fitness do a treadmill test and use a standard protocol, and the speed and incline keeps going up, and you see who gets the highest level. And then we can get what's called an estimated METs, which is the common way, most even clinicians talk about fitness. The fitness ends up being a stronger predictor of prognosis than almost anything. So the heavier person who's fit, they can do very well. Whereas the thin person who's not fit is in big trouble, because they usually are people who have low muscle mass. They could even be cachectic. So the thin person in our society, realizing there's not a lot of very thin people in our society anymore, but the thin person who's not fit is got a higher risk for almost everything. Now, it's well known that the underweight, people who are actually underweight, and that's defined as having a BMI, body mass index, less than 18.5. But even in our society, if someone's got a BMI of 21, which, again, that, a BMI of 20, 21, a lot of people who are star runners, might have a BMI like that. But they're very fit. Mm-hmm. And so if a person's thin and they're very fit, they're going to do well. And we know that in the studies that if you correct for fitness, then fitness ends up being more important than the weight.
What about long term? So let's take in the same example that you gave. The lean person who came out of high school, 180 pounds now, he's sitting in your office, he has cardiovascular disease, or is concerned about it. But they're both in the same situation heart-wise. And that 260-pound person also in your office, they both came out of high school at 160. But the heavier weight person was exercising. Now they're both sitting in your office and you tell both of them, hey, I need both of you to exercise. And I need both of you to eat this. They're eating the same type of meal, there's no genetic predisposition for either of them, but they're eating the same things. And, this is a test tube, right? We're testing this. Out of the two, which one is going to recover better, and be healthier long term?
So if both of them can achieve the same fitness, if both of them can, improve their fitness, they both should have a very good prognosis.
What do you think would be, or one of them might suffer from the overweight person?
So I mean, again, if everything else is even, so it's never everything is exactly the same. Let's say everything else is exactly the same. The coronary disease is the same. The pumping ability of the heart is even. Generally, fitness ends up being the most important thing. The thing about carrying weight, though, is that when people gain weight, a person went from 160 to 260, they mostly are gaining fat. But when they're carrying around all that extra fat, it makes you gain some muscle too. So heavier people tend to have a lot of fat, but they have more muscle.
So is it?
Whereas a thin person who's inactive, when a thin person is not active and they're not fit, they can have very little muscle. And so having low muscle mass is very bad. And in a thin person having, low muscle mass, low muscle strength is a predictor of bad prognosis.
So is it fair to say that the person who's that 260, they're kind of carrying around a weighted vest all the time, and that they lend itself to allowing them to have improved cardiovascular ability because they're having to work harder, so their heart's working harder, their pulmonary system's working harder, and then as they start to lose weight, they've actually kind of gone down a hard path to get better almost.
Yeah. And that's correct. And so and looking at weight loss, when people lose weight, which again, if somebody's really heavy, there's a lot of good features about losing weight. But when many people lose weight and they're doing it strictly by diet, or they're doing it strictly by obesity shots, medications that are very effective now for losing weight, they mostly they lose fat, but they also lose muscle too. And so if that person who's losing weight was doing some physical activity and exercise, and particularly doing some resistance exercise like weight training, that would prevent the loss of muscle mass. And so that would be a more ideal situation, would be, when you're losing weight, if you doing exercise to maintain your cardiorespiratory fitness, but you're doing some muscular exercise, resistance exercise, weight training to maintain your muscle mass. It's hard to gain a lot of muscle mass when you're losing a lot of weight, but you can prevent some of the muscle being lost by doing exercise training and resistance training.
You brought something up about some of these weight loss shots, and they're big on the market right now. I mean, I drove by a corner on a road not far from my house, and I saw a sign that said, basically get your shot and lose some weight, and it's these semaglutides. So what is your philosophy around that? Like, How do you think about that? How do you?
I actually think that I do think that, and it would be better if people didn't gain the weight in the first place. Second, if once they gained the weight, it'd be better if they lost the weight by diet and exercise. The problem is though that that's not happening. Many, there are a few, it happens occasionally. There are people that are very success stories. And if you give people tremendous incentive, they have TV shows about the Biggest Loser, and you give people incentive and you're going to get a big paycheck if you lose a lot of weight. Well, people will lose a lot of weight. People can do it if they have super incentive to do it, but most people don't have the incentive to do it. And so what happens is, even if they kind of lose a little bit, they don't lose a lot, or they lose a bunch because they really do it hard for 6 months and then they gain it all back. And so that's the advantage of the shots is that they've been shown to be pretty safe. They've been shown to be highly effective. It gets people to lose weight. The problem with the shots is twofold though. More than that now, because, sometimes people do have GI side effects from them. That another issue with them, they're very expensive right now. The price will be less as years go by. A third is that when you go off the shots, most people slowly start gaining the weight back. And then last, that when you lose the weight with the shots, you're losing muscle mass too, which isn't all necessarily a good thing. Whereas, for example, if somebody was doing the shots, but was doing some exercise, and doing some weights to prevent the muscle mass loss, we have a term that we've called that actually Ross Arena, a colleague of mine, actually came up with this term, but he calls that pharmacize. And that's like using the pharmacologic drug with exercise. And pharmacize would be a very good way to lose weight and be an exercise that would help keep the weight off, but also, maintain muscle mass.
So do you think it has any, in your profession as a cardiologist, do you think it has any impact or effect on the heart, them taking, semaglutides because a lot of them, the reality is it's a quick solution. It's a magic pill. Right.
So there is evidence that's starting to accumulate that people with heart disease, at least, or people with diabetes with these medications are getting actually reductions in clinical events. So not only are they losing the weight, but they're having a better prognosis. Yeah. I don't think there's been I don't know if there's been a study with the meds that have actually shown better survival, but they are showing at least better overall clinical prognosis as far as cardiac events. And that's just in the last couple of years that those papers have been coming out. Originally there was papers coming out years ago that you lose weight, but now there's actually evidence that you're getting clinical event reduction with these medications. Now, the problem is most of these studies are short term, a couple, 2-year studies, 3-year studies. If then they go off the medication, most of them are going to gradually gain the weight back. So they either have to stay on the medication, or when they go off the medication, they'd have to have something else that can help keep them the weight off. And obviously if they could do the diet and exercise, that would work, but they didn't do that in the first place. If they did it in the first place, they wouldn't have gained the weight. Now, there's no question though, if somebody's very heavy, it starts to be hard, even though they've been carrying around this weight. So they're getting some exercise by just carrying this, extra 100 pounds. It's a lot of weight to be carrying around. So they're getting some muscle build up because of carrying this massive load, around every time they walk anywhere. But when people get really heavy, it's hard to do a lot of exercise. And a lot of times it's easier to exercise, if you're thinner, even if a thin person like you gained 30 pounds and you wouldn't like having 30 pounds more on you, but you wouldn't be, morbidly obese if you weighed 30 pounds more. But if you went out and tried to run, you wouldn't run nearly as good. You wouldn't be able to bike nearly as good. You wouldn't be able to swim nearly as good, and so even a little bit of weight, and then you're talking about a lot of weight, it gets hard to exercise. And so then if you get people to lose 20, 30 pounds, then they all of a sudden are able to do more exercise. So being able to walking that mile is easier, and that's for many reasons. Some of it is cardiopulmonary, but some of it is simply, that, it's from a muscular standpoint, it's easier on the joints, easier on the back, and so many people can exercise way better at lower weights.
When you're going through this process, I want to circle back to, you talked about DEXA scans and different ways to measure visceral and subcutaneous fat, or just to measure lean body mass. But you also mentioned in your book, and if I'm not mistaken, the participants in those studies were based on body mass index, which is height over weight. And I am considered obese. Well, overweight, I think, on the body mass index based on my height.
Well, not only, I would have thought you would be, I would have thought your BMI just, again, I'm looking at on a camera and sitting down, but I would have thought your BMI would be just 24, 25, but maybe it's 26 or 27, but saying that, almost every middle linebacker in the NFL would be considered obese, because most of them have a BMI over 30 and they're solid muscle.
Right.
And so that's the thing. The BMI is not perfect. It does in our society. I mean, there's very few people with a BMI of 35 who don't have a lot of fat on them. But even there, two people could have a BMI of 35 and they both are probably going to have a fair amount of fat, but one could have a lot more fat than the other. And that's because the other has more muscle than the other. And so the fat muscle combination may be different in people who have exactly the same height and weight.
So in your study, this is, I would assume most of the people weren't those middle linebackers. And so, right, because that would just totally skew your results. And you were,
yeah. But again, even in our study, there's going to be differences in the amount of muscle people have, and not all the studies. In fact, most of the studies didn't do that. But the most thing that has been done is there have been studies that measured waist circumference, which is a good surrogate and a simple way to get an estimate of visceral fat. Because central obesity is worse than general obesity. And some of the studies measured percent body fat. We had a study published 15 years ago now that was of 10,000 coronary patients, and we measured BMI, waist circumference, and percent body fat. And we showed the obesity paradox in all three of them. So even, but we only showed the obesity paradox in those who were in low levels of fitness. So we showed that those who had, all of them had treadmill tests to measure their fitness. And those who were in the bottom third, the bottom tertile of fitness, had a much worse prognosis. And there was an obesity paradox. So among the unfit, having a little bit higher BMI, having a little bit higher waist circumference, having a little bit higher percent body fat, they did better. If you were fit though, and our study we didn't have super fit. We defined fit as those who didn't fall in the bottom tertile. So if you were in the top 2/3, which is again, that's not marathon runners and that's not people high athletes, but they just were relatively fit. They had a good prognosis regardless of their body composition, regardless of their BMI, their waist circumference, their percent body fat. The obesity paradox appears to almost totally pertain to people with low levels of fitness.
What's the what is considered low level of fitness? Because you're measuring this on VO2 max, right? Or is it METs?
Well, no. So we have had studies where we use VO2 max, but even our own studies, many of them use the estimated METs based on speed and incline and time on on standard treadmill tests, where you get the estimated METs. And so generally unfit is defined as those falling in the bottom, and it's defined differently in every study, but it's defined as either those falling in the bottom quintile, which is the bottom 20%, the bottom quartile, which is the bottom 25%, or the bottom tertile, which is the bottom 33%. And so different studies define it, and again, the more unfit you have, the bottom 20% is worse than the bottom 33%, because some of them are going to be a little bit more fit than that. But that's usually based on age and gender. And so you predicted, almost every time the older people are going to have a lower estimated METs or a lower peak VO2. But for their age and gender, men have higher fitness typically than women, and older people have lower fitness than younger people typically. And again, there's lots of exceptions, but the average fitness is going to be way lower in older and in women. And so when we place people in the bottom group, we usually base it on others in their age and gender. So they rank low in their fitness score
based on the group
for their age and gender.
Okay. So what would that number be? Because I want to try and give a number to the listeners on, because almost everyone can just go jump on a treadmill and get their METs. And get measured. So almost always people who are less than 5 METs are going to be at pretty low levels. Okay. But again, 5 METs, 7 METs in a 30-year-old is pretty low. Whereas 7 METs in an 80-year-old is pretty good. Yeah.
And so it is age and gender dependent. And so it's hard to pick a certain number. Now, I can tell you from studies that we recently published on the METs that the estimated METs, which people can get on their own, the people who got 14 METs, estimated METs, had an excellent prognosis. So again, there'd be a lot of people that can't get 14 METs if they did a treadmill test on themselves. Yep. But if they got 14 METs, they ended up having like 75 to 80% better survival than those in the lowest level of METs.
Could you take someone who's been through, let's say, maybe they've had some stents put in, and maybe they're on medications for heart disease. The reason why I'm asking this is because a lot of the gyms that are listening, or fitness trainers or coaches, or even just parents, right? They might be in this situation and they're done, right? The insurance is no longer going to pay for them to keep going to the hospital to, work there.
Do cardiac rehab.
So that's over. So now that they're done with that, they've done their rehab and they're out on their own trying to get fit again, right? They're trying to follow the advice of like, let me stay fit and healthy. And they're listening to this and they're going, well, 5 METs, 7 METs, like, I've got to have a number in my mind that I've got to like reach based on my age. Is it okay for them to kind of work up to increase the level?
I mean, absolutely. I mean, first of all, there's going to be very few people that are at 5 METs that are going to be able to get themselves up to 4 METs. But a lot of people can increase their METs. Typically, we've shown in cardiac rehab, if we use the estimated METs, the average person gets a 35% increase. If somebody's at 4 METs, a 35% increase would get them to 6 METs. if somebody's at 10 mets, a 35% increase would get them to 13, 14 mets.
And simply
and
by
so
that,
people can get, and that's the average. And typically the people who are lower get a higher percent improvement than those who are high to begin with. And so that's one. And so, and then some people can do way more than the average, but probably because they're training a little bit harder and they're working a little bit harder. They may be doing a little bit more, intensive workouts, maybe doing high intensity interval training as opposed to just, walking slow. But certainly most people can improve their mets, and at least by 1, 2, or 3 points. But really some a lot more than that.
No contraindication for, if they have stents or if they're on medication, they're past the rehab. They can go in, they can start exercising, they can, work their cardiovascular ability up beyond what they've done in the rehab.
So there would be a few, if somebody's needs to get several more stents, or somebody needs to get a bypass surgery, or somebody needs to get a big valve replacement. Well, they wouldn't want to be exercising hard until they got that treatment. Once they got that treatment, everybody can be exercising. Now, again, we do it a little bit better than that. We might do a stress test on them, and we ask them, we examine them. We know what their heart strength is. We ask them, are you having any bad chest pain or shortness of breath? But people there's very few heart conditions now that people are told not to exercise. So, there used to be, and there still is. There's a lot of gyms will want people to, older people or people who've had heart attacks to get their doctor to sign a release that it's all right for them to exercise, and we make a joke about it because you don't need to get a release to go and eat fast foods and get Big Macs and eat all kind of calories and sugar and fat. But you need a release to exercise. That makes, there's hardly anybody do we tell a patient we don't want you to exercise, and now there might be some people that we know their heart's bad. We might tell them, listen, at this point in your life, you don't need to be trying to race. You don't need to be trying to get into marathons. You don't need to be going out and running when it's 100 degrees with the 100 heat index, in New Orleans, Louisiana. But we don't tell anyone, even that people that have pretty significant heart disease, exercise and improving their fitness improves their prognosis, sometimes even better than the very good medications that we're giving them. So fitness is one of the biggest predictors of prognosis and survival in almost any condition. So getting more fit, and I like to say fit is it, for many conditions. It's probably one of the most important things people and probably the vice versa of that. One of the biggest threats to the health of the population in the 21st century is lack of physical activity. Mm-hmm. And sedentary behavior. And so getting people to get more physical activity, more exercise, and to reach higher levels of fitness is always a good thing.
What would be the real marker of health that everyone should be tracking every month? Or if it's not weight, right? What is it that they should be tracking that would be the marker of their health?
So I do think that a simple thing for people to track, would be their steps. There's other things people can track, but a very, very easy thing for most people to track would be their steps. And if you tracked steps and sleep, so you don't want to get too much sleep, but you don't want to get too little sleep. For most people, shooting in the 7 to 9 hours, is the right amount of sleep. And certainly, very few people are doing well if they're getting less than 6 hours sleep. And then people are sleeping 10 hours. That's not good either. But so sleep is important, and steps is a way that one can simply measure physical activity. Now, again, there are better methods for people who want to take it to higher levels, but just a simple thing that they're so easy to get a step counter. It's available on all the phones. There's the smartwatches. There's relatively inexpensive ways people can count their steps, in a fairly accurate way. And again, for many years, everybody was told, you need to get 10,000 steps. And we know that was totally based on Japanese advertisement from 1964. So there was no science behind that. We know that in papers that even getting 2,500 to 3,000 steps, you start getting some benefits compared to less steps than that. And it looks like in the more recent research that you seem to maximize out your benefit for cardiovascular disease at something like 7,200 steps per day, and for mortality at about 8,800 steps per day. Now, there's nothing wrong with getting more steps than that because you burn more calories, you get more relaxation, but getting 18,000 steps might be, you may need to do that for training if you're training for races. You need to do it faster steps too if you're going to be racing. But if you're just doing it for health, you can achieve the health benefits at pretty reasonable amounts of physical activity. And again, there's a lot of people who are getting 2,000 steps at 2,500 steps that would easily be able to get 5,000, 6,000, 8,000 steps a day, and achieve, what at least the statistics look like giving them, maximum cardiovascular disease and mortality, protection. And again, there was a big paper in our leading cardiology journal, JACC, that did a meta-analysis of like a large number of studies in over 100,000 people that showed that you start to get the benefits at 2,500 to 3,000 steps per day. And you seem to maximize out from cardiovascular disease events at around 7,200 and for mortality at around 8,800 steps per day. That's way less than the 10,000 steps. And many people could achieve that or come close to that, but just going out and doing 30 to 40 minutes of walking or bicycle or things like that.
So, for you, what is your daily fitness routine look like right now? I mean, I know that.
So for many years, I basically try to do weights once or twice a week. And I think sometimes with my schedule now, I'll have some weeks that I do 2 or 3 times. And then some months I'll do three weight sessions in the month. I was pretty much running every single day, 45, 50 minutes in the weekdays and like an hour and a half on the weekends. Due to some back issues lately, I went just recently. I went 1,099 days, which is 3 years and 4 days, where I did not miss a day running. And that's including traveling to India a bunch of times, to China a bunch of times, giving lectures, so I'd run before I'd get on the flight. As soon as I get to the hotel in India, I'd run. Okay. But now what I've been doing lately, I really missed, I had to take 5 weeks off of running. Because of the back and piriformis muscle. But now what I'm doing is I'm making my runs shorter. I'm doing bicycle and elliptical machine. And then after I'm really warmed up, I'll go out during the week for 15, 20 minute runs, the weekend for 30-minute runs. And that's allowing me to, so the combination of the bike, the elliptical and the running is my main thing now. And like I said, I'm still trying to do at least once. The guidelines say 2 times a week of resistance exercise. We published a paper years ago, in medical science, sports and exercise, where we showed that you looked like you got the maximum benefit from a cardiovascular clinical event standpoint, with even just doing one resistance exercise, bout per week.
How long?
So I'm really trying to do once or twice, per week. And I probably most months end up doing 4 or 5 times, but I'll certainly have a month where I just did 3 times. of resistance exercise. I never miss a day of the aerobics though.
What's the strength training about? Like how long do you need to be strength training?
So my strength training probably ends up doing it only 10 to 15 minutes. So I'm fast. I do 15 reps and then I do it on several machines. And I do it all the major muscle groups. But I don't spend time in between, my heart rate's a little bit high while I'm doing the weight training.
So you've researched a lot. You've studied thousands of lives. What would you say that the longest living, most vibrant people that maybe the current research topics or textbooks don't talk about, what are they doing?
I think most of them are being physically active. Some of them clearly have really good genes, because one of the best things you can have for your health is to have really healthy parents, who gave you good genes. So that really helps you, but not everyone has that luxury. So a lot of people have parents that had a lot of health issues and died young. And so I think most people who are doing well are getting physical activity or not having prolonged sedentary times, not sitting 12, 14 hours a day, probably eating healthy diets, avoiding at least the fast foods and avoiding high amounts of alcohol, avoiding drugs, avoiding smoking, and getting a decent amount of sleep. And a decent could be, I think a general decent, I would say would be 7 hours. But honestly, for some people, they feel perfectly good with 6 hours sleep. And I know I probably, as a young person, I had a lot of nights where I was getting 5 hours sleep with the workloads and the papers and lectures. And now I wouldn't be able to go too many days getting 5 and 6 hours sleep. I might be able to do it one night. But I'd like to get over 7 hours sleep now, where in my and I'm going to be hitting 67. But, when I was in my 30s, I could easily have several nights straight with fives and felt good. I think as you get older, more people need, a decent amount of sleep. And so those would be, and I do think of all of that, probably the most important is physical activity.
What would you say is a non-negotiable for you, for your health?
Well, I think that, it's hard to say smoking would be a good thing. So smoking is something that clearly is bad. And granted, a smoker who is fit is better off than a smoker who's not fit. Mm-hmm. But smoking does bad for a lot of different organs in the body. But really, in my book, I think you might have seen that I said that sitting is the new smoking. Mm-hmm. Because now people are sitting so long because they're sitting at their desk, they're sitting at their computer, they're sitting watching TV, they're sitting with their phones. So it's just, they can be prolonged sitting, so avoiding prolonged sitting by standing while you're working, getting up every 30 to 60 minutes. And even if you just walk around for a minute or two, preventing the prolonged sitting. Many people will say they have times where they go 4 and 6 hours straight without getting up. Mm-hmm. One time, so I think, I think physical activity, does negate or does prevent some of the bad things that happen from prolonged sitting. So people who are very physically active, they don't get the adverse effects of the prolonged sitting the same as people who are not physically active. But the ideal situation would be to be physically active every day, doing, those number of steps, 8,000, 9,000, 10,000 steps or at least 6,000 or 8,000 steps, and then not only doing the physical activity, but preventing prolonged sitting, trying to make your sitting, less than 8 hours a day, but certainly less than 10 hours per day. And when you are sitting, get up every, period of time.
If, I got one last question for you. It's kind of encapsulating everything that you've done. If your book, all of your research, and really all of your life's work were to be remembered in one sentence, what would that legacy line be for you?
Fit is it. And the biggest threat to health in the 21st century is physical inactivity.
Yeah, I'd agree with you. I think we're getting more prone to being inactive simply because of convenience. So everything is it gets more and more convenient, and the more convenient.
Yeah. So if you go back five decades, people had to be physically active to get through today. 5 decades ago, you had to work for your food. You had to just to keep your house up. Women had to do a lot of physical work. And now the amount of physical work, you can do everything with buttons. So it's become with industrialization, with all the machinery and the technology that we have, it's allowed people to be more inactive. Back 5 and 6 decades ago, people didn't have to go to the gym to get exercise. They were getting exercise in their daily life. And now most of us, if we didn't go make ourselves exercise, we would get not so much physical activity. So, like you said, now you're sitting at your job, you're doing computer work, you can go home and, sit and watch games and TV and do play on games on your machines. And so you can get long periods of time where you're not getting, physical activity. And so it takes a little bit of effort now to make yourself be more physically active. So you have to tell yourself, I have to go out and walk. I have to go to the gym. I have to do some weights. I have to do push-ups, we didn't talk much about, I think, and I probably don't even do this as much as I should. Doing work with your core, is helpful too. And then as you get older, particularly people in their 80s, they need balance exercise, to prevent falls, and things like that. But I think if you make it just simple though, the simple thing would be for people to be doing, getting steps on most days and doing a resistance exercise or 2 times a week. Then they would be getting the physical activity. And then if you can get a little bit better sleep and avoid the high alcohol and the drugs and the smoking, I think then you can do well. And you actually, if you did all of that, you could almost do well regardless of your weight. Now, again, it's always better not to have too much weight. And again, there's not going to be too many people. There's a lot of people that have a BMI of 27, 30, 32 who are pretty healthy. There's not too many people with a BMI of 45
right, or
50 that are very helpful. And in our society now, 9% of the adult population, that's 1 in 11 people, have a BMI over 40 in the United States. So we have a lot of people who are not just a little bit, overweight or mildly obese, but they're very obese. Yeah. And they're carrying so much. And we used to call that morbid obesity, and that's kind of a mean term now. So now it's called class 3 severe obesity.
Well, hey, but it's true. Whether you call it class 3 or morbid, I mean,
yeah,
the reality still exists.
Yeah.
Yeah.
So, so again, I do always like to point out that the perfect world, everyone would remain lean and fit from childhood to old age. And that would begin with getting our kids more active. I mean, right now, not only, so when I was a kid, there was hardly any heavy kids. Now there's a lot of kids that are already pretty heavy. So you can imagine if a kid's heavy at age 8, he's going to be in big trouble at age 30 and 40. And so the perfect world would be being lean and fit from childhood to well, in adulthood. And like I said, that's not happening in our society. Most people are gaining a lot of weight and they're losing fitness as the years go by. And I would say that the perfect would be trying to prevent both. But if you're going to do one of the two, it'd be better to gain a little bit weight, but maintain the fitness than vice versa, because fit is probably more important than fat.
Thank you, Dr. Lavie. So really appreciate you coming on today. I think there are some other things that I wanted to round out, but I know that time is limited. But any place that anyone can go get your book, I know I found it on Amazon. Where can everyone else find it?
So it's the book's been out since 2014. So it's not in as many bookstores anymore as it would have been, 11 years ago. So probably Amazon would be the best place now. But again, I think that I don't need to at this point. I don't need to be selling the books. I think that people can get this idea from what we just talked about.
No, I appreciate it.
And save them some money on the book, which I don't think the book's too expensive anymore anyway. But no, and again, I appreciate your comments about the book, and it ended up being a good thing for me to do it. And I've published a lot of medical papers and I've published 2 cardiology textbooks, but it's the only kind of book that I've ever done for lay people.
Yes.
And so, it's something different. And so,
well, in layman's terms, I think for most of the listeners, even me, sometimes when I'm looking at research articles, it's hard to digest all the information because it's terminology that maybe not everyone's used to trying to understand or put together. So it was good that you had the book out there, and I'm really happy that we were able to cover it, because at the end of the day, what I think everyone needs to understand is fitness is the king. That's what you got to follow. And you can kind of cover all facets of health just by being fit. And we're not getting that in today's society. We're struck by being in a vortex of watching newsreels or whatever on our phones and staying on our computers and using technology as a means to stay in front of a place where we can be sedentary. And that's a huge disadvantage for us.
Yeah. And certainly, I mean, there are a lot of people who are fit, and there's a lot of people that are doing races, when they're 30, 40, 50, 60, 70, 80 years old. But that's the minority. It's not so, again, a lot of times people will ask, is there too much exercise? Is there, and truthfully, there, people who do marathons and triathlons, they're not doing it for health.
No,
they're doing it for competition and fun. And, they have reasons to be doing it, but it's not for health. You can get the maximum health benefits at much, much lower levels of exercise. And there are some there are some negative effects about doing too much. I don't ever try to talk people out of doing it, because the problem in our society is not too much exercise. It's too little exercise. So there's not too many people who are dropping like flies because of a marathon or a triathlon. It does happen, but it's way, way less than the people who are dropping like flies because they've been a couch potato, for the past 30 and 40 years.
Yeah.
They need to get off the couch and do some physical activity.
Totally agree. Dr. Lavie, again, really appreciate having you on. And for everyone who's listened to this episode, just like you said, he's not here to promote the book. He's here to promote health and wellness and staying fit. You can get most of that information from the show. But if you want to get the book, you definitely can find it on Amazon. That's where I found it. Again, Dr. Lavie, thanks for joining us.
Thank you, Michael.